profile. She says 10 years. I can't remember when exactly. But we connected while I was still in Mpumalanga there at Right to Care. And she has since really grown in this HIV medicine field. She's part of our instructors for the diploma programs. I think for child health, Christy, we had you there, but also for the HIV diploma, but also for the HPCSA board preparation. Yeah, we do a lot, colleagues. Sometimes I lose track of what we do. So Christy has been at the background, doing a lot of work. So I've asked her to say, man, just come to the platform. Let's introduce you officially to the colleagues. She's going to talk about vertical transmission prevention. This topic is important because there's an uprising or an increase in congenital syphilis. So we don't want any child really to get this manageable condition. So just to read her profile, because this is the first time she's here. She is a medical doctor. She's got over 10 years experience in the field of HIV care and treatment. She holds a postgraduate diploma in HIV management from the Colleges of Medicine of South Africa, as well as a master's degree in tropical medicine and international health. She worked as a senior technical advisor for Right to Care in Mpumalanga between 2016 and 2025, and is hoping to remain involved in public health. I guess I must change that a bit, Christy, because I know that you are involved and maybe it's direct care. Happy are those who get to be managed by yourself, Christy. So can I hand over to you, Dr. Christy, to say hi to the colleagues and then take us from here? Thank you.
Thanks, Lesego. Yes, I think I must send you a slightly updated one so that we update the last sentence. I think that was written in the beginning of the year when things were a bit uncertain. Yeah, hi everyone. I'm glad to be here with all of you. I thought it was interesting now, Lesego, that you spoke about VTP, that it's a South African thing and that we are using that. Because I actually got the idea recently that it's not just in South Africa that we are using it. I saw some documents. I can't remember if it was from IAS conference or if it was WHO. I can't remember exactly, but I saw there were some international documents that also spoke about vertical transmission prevention. So other colleagues might also be. I think everybody is moving sort of in the same direction.
Yeah, we are leading.
All right, let me try to share
colleagues.
Slides. You can let me know if it's visible.
Yeah, a few seconds. Yes, all is visible and it's full screen. Thank you.
Okay, I'm going to turn my video off just to share some, to save some bandwidth. All right, so this evening we are going to talk about vertical transmission prevention of syphilis. Syphilis is actually a really interesting disease, but we're going to focus more on the mother-to-child transmission or vertical transmission part of it this evening. Oops, what's happening now? What did I do? Okay, looks better. All right, so just to remind ourselves, syphilis is a bacteria. It's a gram-negative bacteria. And it's called a spirochete because it's got this kind of spiral form. So I don't know if it really has a face like that. This little guy looks like he's plotting something. But as we all know, it can be transmitted through sexual contact or it can be transmitted from mother to child. And it's a really interesting disease because it can have so many different presentations. I have a few slides showing the different stages and all the different symptoms it can present with. But it can also be asymptomatic. So it's quite a challenging disease. It's an ancient disease, right? They found syphilis in some of these ancient mummies and ancient old graves that they had dug up from hundreds and hundreds of years ago. It's a really old disease, but it still manages to confuse clinicians sometimes, even though we know so much about it. And it's quite an interesting condition. So just as a brief overview, we know that we get primary syphilis, which is typically presenting as a painless ulcer that we call a chancre. Then you can have secondary syphilis after that, a few weeks later. We'll talk about the symptoms of that. And then tertiary, then it goes latent for a while, and then you get tertiary syphilis after many years, which then involves more general symptoms. So on the picture above, it shows us a simplified version again of stage 1, which can be after a few days of infection up to about 90 days or 3 months. So you can have a kind of an ulcer like that. Then stage 2, we'll go through the different signs and symptoms on the next slide, but this one is showing the typical palmar rash that you can get. And stage 2 or secondary syphilis can be a few weeks after that initial infection. So the slide here from the bottom, from the graph here at the bottom from the Clinician Society guidelines, shows us that it can be around 3 months as well. And then stage 3 or tertiary syphilis can be many years later and then affect some of the other organ systems. So this looks a bit complicated, don't worry about it. But what I'm trying to show on this slide is the early phases of syphilis is when it is actually infectious. So what do we mean with early? Early, we count primary syphilis and secondary syphilis and the early part of latent syphilis. So early latent is usually the first 2 years after the secondary syphilis. Then when it comes late syphilis, they are actually less infectious. So the late latent phase and tertiary syphilis, they're actually less infectious. So that's the one thing I wanted to show. The other thing was the incubation period here. This thing says 17 to 28 days. And then the green line here showing our tests, our syphilis-specific tests, which can include our rapid test that we have these days, or the TPHA that we can do at the lab. So in the beginning, it will still be negative. This is why it's called the window period. It means you're already infected. The tests will not show up positive. And then once the window period is over, the test shows up positive, and then it will remain positive lifelong, which is an interesting phenomenon that we need to keep in mind. We'll talk about that more later on. And then your RPR, of course, that we also do, the titer will be very low in the beginning, and then it will peak later on. And then depending if you are treated or not, it will become negative again. Sometimes it can stay positive for quite a long time, but this one fluctuates a bit, the RPR titer, where the rapid test or the TPHA will stay positive. I hope I didn't confuse you with the graph. Let's look at some pictures. They are much nicer. So again, the primary syphilis, you will have this ulcer. Typically, they are painless. So the patient might not even know that they're there. It can be painful sometimes because with syphilis, anything is possible, but often they are painless. And it typically occurs on the penis or the labia, but it can appear in other sites as well. It can be around the anus, it can even be around the mouth. And because it's sites where the patient might not necessarily see it, they might not even know that they had this ulcer. But if they have the ulcer and they present to the clinic and we see it and we treat it for it, it will disappear. But if they don't get treated, either maybe because they are shy about it, they don't want to come and tell someone they've got ulcers on their genital areas, or if they don't even know about it, it will just disappear by itself, spontaneously, after a few weeks. Then, if the person was not treated, a few weeks later, around about 3 months later, you will get secondary syphilis. So secondary syphilis can also present in a few different ways. It can have that typical rash, especially that rash that involves the palms and the soles that I showed you on the previous picture. About 50% of patients have that. They can also have lesions in the mouth. They can actually have neurosyphilis in the secondary stage already. So if the brain is involved and it's neurosyphilis with typical meningitis symptoms, headache, neck stiffness, those sorts of things, that's actually secondary syphilis. Also cranial nerve deficits like we see on the picture here with the eyes. They can have other eye symptoms as well, like uveitis, where there's inflammation in the eye. They can have condylar martellata, which are those things that looks a bit like warts, but they are like fleshy and soft. They're not like cauliflower warty. They're just like soft little lesions. It can also involve the liver or the kidneys in secondary syphilis, but it's not as common. Then the patient might seek treatment. We might find them. We might diagnose syphilis and treat them. Or the patient will delay. They don't think it's that serious. They don't have time. They can't take time off work. What will happen if they are not treated? They will get better spontaneously. and that they will just be reassured that whatever this was, it's gone, and they didn't seek treatment, but they are fine, right? But they are not really fine. They still have syphilis. They are just now in the latent phase. So this is this period of asymptomatic infections. So they are infectious in the primary and secondary stages and in the early latent phase. So the first 2 years after they moved out of secondary, they're still quite infectious. That's why it's so important that we find them and treat them, because we don't want them to keep on passing this to their sexual partners. Then after the first 2 years, they move to latent syphilis. And then many years later, it can even be decades later, they might move to tertiary syphilis. So here, we can also have involvement of the brain, which we will also call neurosyphilis. But here, they typically present more with a dementia-like picture, where in the secondary syphilis, the neurosyphilis is more of a meningitis picture. But here, it's more of a dementia picture. They can also have these ulcerating granulomas, and they can also have cardiovascular effects. So they can have aortic aneurysms, they can have leaky valves, because everything is like stretching, like the connective tissue is affected. So they can present to surgery, they can present to cardiology, they can present to neurology. So wherever we are working in the hospital as doctors, we actually we need to have a high index of suspicion. You might ask the patient, did you have a genital ulcer before? Did you have a rash on your palms? And they might say no, because they didn't know about the ulcer, or it's so long ago, or they never had the rash, So it's difficult sometimes to know from the history what really happened. So we really need to have a high index of suspicion. So that's just general overview of syphilis, but this is a VTP lecture. So we do want to talk about mother-to-child transmission. And in the last couple of years, we've started including syphilis in all our HIV VTP lectures and guidelines in South Africa, because there's actually been a resurgence of congenital syphilis cases in South Africa. It's still quite a big cause of preventable perinatal deaths in South Africa. If you look at your infant mortality reports, it's there, and it shouldn't be. It's a preventable condition. So in 2019, the prevalence of syphilis was estimated at 2.6% in the antenatal population. It actually increased. I'll show you on the next slide. It's increased even more after that. When the specialists were sitting down, or the public health people were sitting down, saying, why is syphilis going up? They thought maybe our patients are not coming for antenatal booking. Or maybe they are coming for booking, but we are not doing syphilis. Isn't it? It was our guideline that we do a RPR at the first booking visit in antenatal. But they looked at the numbers and they saw we actually have very good coverage of syphilis screening at the first antenatal visit. And we also have quite good antenatal attendance. So if our patients are coming for ANC booking, and we are testing them for syphilis at the first visit, why are we missing so many cases of congenital syphilis? I'll show you now what strategies they came up with to try and overcome this. And why do we want to prevent it? Why do we not want congenital syphilis? It's because if there's syphilis in the mom, you can have adverse pregnancy outcomes in up to 80% of cases where the mom has syphilis and she is not treated. And adverse pregnancy outcomes can include anything from miscarriages, stillbirths, and congenital syphilis. So South Africa is committed to dual elimination of both HIV and syphilis. And there's a few strategies that we have come up with in the last few years to try to achieve that. This is just a graph showing you how the prevalence of syphilis has increased in the antenatal population. This is a few years between each of these, and you can see it's on an upward trend. Of course, there's also a few other things that might be in play. We had quite a long period in the last few years where we had penicillin stockouts. So we can't be surprised about congenital syphilis rising if we didn't have penicillin to treat our patients with, right? And as far as I know, the penicillin shortages started improving, but I saw this worrying article quite recently, last month, that there might be more penicillin stockouts around the corner. So we will have to see how we deal with that. Also, I saw this article that showed male condom distribution has actually been dropping over the last few years. If we don't have penicillin in all our facilities and our condom usage or condom distribution is dropping, you can just imagine what that will do to our syphilis prevalence. Okay, so we can, that was just the introduction. We'll spend a bit of time talking about the mother, the pregnant mother, how we screen her for syphilis and how we manage it if we find it. And then we'll go over to the baby. So let me just get back to those strategies that I said. What strategies did our public health, Department of Health colleagues come up with? So we said we have good antenatal attendance, we have good syphilis testing at the first visit, but yet we have high numbers of babies being born with congenital syphilis. So how can we improve that? They came up with two strategies, which we'll discuss in this section. The one strategy was to not only test the mothers at the first visit, but rather to test them at each and every antenatal visit or at all the bank visits, the same as what we do with HIV in our HIV negative clients. Because some patients will test negative for syphilis at the ANC booking visit, but they will get syphilis later on during the pregnancy, and the baby will be born with congenital syphilis. So to make sure we don't miss any cases during pregnancy, we will test them for syphilis at each and every bank visit. And the second strategy that they came up with was to say, maybe we do find some of these patients, or we know with our old guidelines, but because we have to send the specimen to the laboratory, by the time the specimen comes back, we see the syphilis is positive, the patient is not there. Then we have to recall the patient, we have to remember to get them back. So some patients will go untreated because there's a delay between doing the test and getting the result. So if we get some rapid tests where we can do the test and get the result at the same time, that will solve the problem. So those are two of the strategies that we've been implementing in the last couple of years in South Africa to try to close this gap to congenital syphilis, to prevent congenital syphilis. So this is what the new guideline is saying. A pregnant woman should be screened and tested for syphilis at the first or the booking visit in antenatal care. And if she tests negative, we will repeat the syphilis testing at every scheduled antenatal visit. Then again, during labor and delivery. Also, if she happens to have an intrauterine death, if she's unfortunate to have that circumstance, we must remember to also repeat the syphilis test. Or any other time if the mom has clinical symptoms or signs suggestive of syphilis. So we don't have to continue testing them during breastfeeding. Unlike HIV, normally we continue testing the negative moms for HIV during breastfeeding. Syphilis, we only test up to the delivery, unless she's coming with symptoms and signs. So we basically test them at the same time for HIV and syphilis. Obviously, if she has one condition, you won't test her again for that one between syphilis and HIV, but you will test them for everything that they've not yet tested positive for. So this is our second strategy, the rapid tests. I hope all of you have seen these rapid tests in your facility. The rapid test is called a specific syphilis test or a treponemal test. It tests for that bacteria specifically. So we have two types of treponemal tests. The rapid test is one, and the TPHA that we can do at the laboratory is another one. And the thing that we have to remember, really important about these tests, is that they remain positive lifelong. Even if the infection has been treated, the patient is cured, they no longer have syphilis, but this test will always remain positive. So we can only use this test for someone who has never had syphilis before. If they've had it before, we can't use it again because automatically it will be positive. It's not giving us new information of a new infection. Really important to remember this if you are using the rapid test. If we have a rapid test and it tests positive, we have to always confirm it with an RPR test with the laboratory. Remember, this is kind of still a screening test. So we always have to confirm it with an RPR, and then I'll show you on the algorithm later how we manage it. how we interpret the results. Obviously, also with the RPR, we get a titer, and the baseline titer will then allow us to see the response later on after we've treated the patient. The titer has to drop. I'll show you that as well. Yeah, this bottom is what I've been saying. If she previously had a positive rapid test, you can no longer use the rapid test going forward because the rapid test can't differentiate whether it's a new or a previous infection. If she previously had syphilis and she was treated, now she's coming again with a new pregnancy, we will use the RPR instead. I'll show you that algorithm as well. This is the one type of test that we have, specific or treponemal. Rapid tests and TPHA fall in this category. The other type of test that we have is the non-specific or non-treponemal tests. And this is where RPR comes in. This is done in a laboratory. You send your TTA tube, your purple top tube. And the benefit of the RPR is that it can change in response to the treatment. So you can actually see whether the treatment is being successful. So we use it to confirm the rapid test. The downside of the RPR is it can have false positives due to other conditions. Some autoimmune conditions and some other things might also give you a false positive RPR. So it's really useful to have both, the specific and the non-specific tests, the rapid test and the RPR, to give us a clear picture of what's happening in the patient. Okay, so when it comes to the rapid syphilis test kits, there are two types. We've got a single test kit, which only tests for syphilis. And we also have a dual test kit, which tests for both syphilis and HIV with 1 drop of blood. 1 drop of blood, prick the patient once, and the same test kit will give you results for syphilis and HIV. Isn't that nice? Because we know in pregnancy, we want to test them at every visit, unless they are known to be positive. So if the rapid tests are available, and if they are appropriate, we say appropriate because inappropriate would be somebody who previously had syphilis. Remember, then we can't use the rapid test again, and it's inappropriate. So when it is appropriate, no previous history of syphilis, and the rapid test is actually the preferred first-line test in pregnancy because it allows us to see the result immediately, and we can already give the first dose of penicillin immediately there on the spot. You don't have to wait for her to come back. You can already start your treatment. So it's obvious that our dual test kit must only be used in patients who do not have HIV, or previously negative or unknown, and they don't have a previous syphilis infection. If they're already known with HIV, we should not test them with a dual kit. Then we should only use the single syphilis test. Because what if we get a negative HIV test in somebody who's on ARVs? Then we have to explain that. So don't cause yourself that headache. Do not use the dual test kit in our ART clients. Use the single syphilis test. So make sure that you have both of them and that you know which one you are using. This slide is sort of saying the same thing. Which test kit do we use for which type of patient? So if they are HIV positive and we don't know the syphilis status, then we will not do an HIV test. They're already on ART. We will do the syphilis single rapid test. If they are HIV negative or HIV unknown, and we don't know their syphilis status, this is where the dual test kit comes in, the HIV syphilis dual test. If they are HIV negative or unknown status, and we know that they had a previous syphilis infection, then we will use our HIV rapid test kit, the one that we've had all the years, and we will send blood for RPR to the laboratory in a tube. We cannot use the rapid test if they've had a previous syphilis. And then if they are known HIV and known previous syphilis, we don't need to test for HIV. We will only send our RPR to the lab. It looks like a complicated slide, but if you think about it, it makes sense. The important thing is that you don't test for something that you already know is there. You will confuse yourself if it comes back negative. Okay, so these are some pictures from some of the rapid test trainings. Some of you might have seen them or might have attended it. So this one is from the first response kits. might have different manufacturers with slightly different procedures. So make sure that you know for your test kits that you are doing it in the right way according to the instructions. For the first response, you will put your drop in the well. You will put 2 drops of the buffer, and then you will wait at least 20 minutes. Don't read it earlier than 20 minutes, but also don't read it later than 25 minutes. You only have a 5-minute window for this one. If you're going to read it too early or too late, you might miss that line that's going to appear. So for the first response, make sure that you follow those instructions properly. And then your results, when you read them after 20 minutes, they might come like this. If you see a line only on the control, then you know it's a negative. Here's the test. So the syphilis test is not there, it's negative. So this person has screened negative for syphilis. If your control and your test are both positive, then the patient is positive for syphilis. And then if your control line is not there, it's invalid. It doesn't matter if the test line is there or not. If the control is not there, it's invalid. So this is the syphilis only test kit, specifically the first response one. This is how it looks. Then we get the HIV syphilis dual test kit. So this one is from Pro. So they have these little instructions. I think it's the same for the others. Clean the finger, prick them with a lancet, wipe the first drop of blood, and then take your pipette, draw up 20 microliters with up to that black line. That's where you pull the blood. And then you will put that in this little well. And you will add 3 drops of buffer. You see the other one was 2 drops, this is 3 drops. So make sure you know which manufacturer, which brand you've got in your facility so that you use the right number of drops. Also, the waiting time is different. This one, the waiting time is 15 minutes. So go and check your test kits, how many minutes you are supposed to wait so that you read it at the right time. And you can see here on this part where you read the results, you've got a control, you've got a syphilis, you've got HIV-1, and you've got HIV-2. So it tests for both types of HIV and syphilis, all at the same time. So what will these ones' results look like? Let's see. So if you have a negative test, you will only see the control. If only the control is there, nothing else is there, then your HIV and your syphilis are both negative. Or it might look like this. The control is positive and the HIV-1 is positive. There's no syphilis. So the patient has HIV. You might have a faint line at the HIV-2 as well, but you can see this person was diagnosed with HIV. Or it can be HIV-2, where you have a dark line at the HIV-2. You might also have a light line here, but the syphilis is negative. So this one only tested positive for HIV, not for syphilis. And then the other option could be that your syphilis is positive, but the HIV is not there. So HIV negative, syphilis positive. Obviously, if your control is missing, it will be invalid, and you could also have that both the syphilis and the HIV come back positive. So there are all these different options. Don't get confused with which line you are reading where. Look very carefully that you are not reading for the wrong line and diagnosing the patient with the vice versa condition. So be very clear how you are reading it. All right. So this is our syphilis treatment algorithm in the VTP guidelines from the Department of Health. We will take it bit by bit because there's quite a lot going on here and I want to make sure we are all on the same page. So we're going to start by looking at the top half of the algorithm. So here you've got your rapid tests. It can be your single syphilis test or it can be your dual HIV syphilis rapid test. We're going to focus on the syphilis part and not on the HIV part. So the woman is coming for antenatal visit. You are doing one of these 2 tests. And you are seeing that the syphilis part of it is non-reactive. There's no line there for syphilis. So if there's no line for syphilis, she has screened negative. As long as she doesn't have any clinical signs of syphilis, we will say that she doesn't have current syphilis, she doesn't have previous syphilis, and there's no further action needed, except next time when she comes for her next bank visit, we will test her again. Okay. Then, if your screening test comes back positive, this is where the benefit comes in. Immediately on the same day, we can give the first dose of penicillin, no delay. But remember, this is a screening test. We still want to confirm it with an RPR, and we also want to see the titer. So we will send a separate blood sample with RPR. And here comes the tricky thing. And I don't know if a lab actually does this well. If somebody has experience with this, you can actually let us know in the chat afterwards when we have some discussions. What we are advised to do is to write on the lab form to say, this is an antenatal patient with a rapid test positive. Please do an RPR. And if the RPR is negative, please do a specific syphilis test, which is the TPHA. Now you can see how small is that block for additional tests on your lab form. To write this whole story might be a bit tricky, but that's the message that we want to get across. We want the lab to know it's a pregnant patient with a rapid test, so that if the RPR is negative, we want them to also do the TPHA. I'll show you what we do with those results. Because otherwise, they're only going to do the RPR, and we want the TPHA as well if the RPR is negative. Okay, so this was our visit. The patient was here. Syphilis tested positive. We've given our first dose penicillin. We've taken blood, sent it to the lab, and now we ask the patient to come back in 1 week. What are we going to do after 1 week? She needs her next dose of penicillin, and we will just confirm that she does have syphilis based on the RPR. Okay, so now we're going to the second part, the bottom half of that page. We'll start on this side. This is the easy part. Straightforward, the RPR comes back reactive, so we know that she does have syphilis. So we counsel the patient, we've confirmed the syphilis, we give her the second dose of penicillin, we look on our lab results, what was the RPR titer, and we write it down. It will be something like 1 in 8 or 1 in 16 or 1 in 32. We see what is the number, we write it down. Make sure, if you haven't done it yet, that we trace her sexual partners as well and test them as well. And then we give her a follow-up date for another 1 week later so that she can have her third dose of penicillin. Then we will monitor her. We will wait at least 3 months before we repeat the RPR titer. We will speak a bit more about the monitoring on some of the later slides. But this is your initial management. The 3 doses of penicillin, if the RPR comes back reactive, you give the second and third dose. Here's another scenario. What if the RPR comes back non-reactive, and because it came back negative and you told the lab the story of the patient, they've done the TPHA, the specific test, it also comes back non-reactive. What does this mean? It means there was a problem with our rapid test, right? This patient does not have syphilis. I'm assuming this is a patient who doesn't have any clinical symptoms. We are only testing her because it's our guideline. We are screening them at each and every visit in pregnancy. So she does not have syphilis. What could have gone wrong with our rapid test, though? There's a few things. Maybe the test kit expired. Maybe we read the result too early because we were in a rush. So we only waited 5 minutes before we read the result. Maybe we waited too long. Maybe we didn't put the right number of drops of buffer. Maybe we were using an HIV syphilis dual kit and we looked at the wrong line. There was lines in different places, and actually it wasn't the syphilis that tested positive. So it was probably a mistake from the clinician or a problem with the test kit. So we tell the patient, the good news is you actually don't have syphilis. You've already had 1 shot of penicillin, but good news, you don't have to get a second and a third injection today. And we will continue screening this patient at each and every visit using the rapid test. Because we can see from the lab results, she's never had syphilis before, so the rapid test can still give us an accurate result. Okay, so both of these are quite easy to understand. Now you have to focus, because now it becomes a bit more interesting. What if the RPR comes back negative, but the TPHA comes back positive? What does that tell us? Remember we said the TPHA falls in the same category as the rapid test, and those are the ones that remain positive lifelong, whereas the RPR tells us more about current disease, and it will go negative later on if syphilis is treated. So if this is the case, then it tells us that the patient had a past infection of syphilis. There's no sign of current active syphilis because the RPR is negative, but the fact that the rapid test was positive and the TPHA is positive tells us there's a past infection. So we don't have to continue treating this patient for syphilis. She's had 1 shot of penicillin last week. She doesn't have to continue with the 2nd and 3rd injections, but we have to continue screening her for syphilis each and every visit. But now remember, for this one, we cannot use the rapid test. This one we can. She's never had syphilis. This patient had previous syphilis. The rapid test will come back positive each and every time. So we are just confusing ourselves if we continue doing rapid test. For this patient, we will do the RPR instead at each scheduled bank visit. Okay, I hope everybody is still following. I'm going to talk about those things on another slide. Okay, so here is another algorithm. What if our rapid test is not available? We don't have them in our facilities. They've not yet been delivered, or we've not yet been trained. The province has told us to wait. Or if they are inappropriate, meaning you have a patient with previous syphilis, you cannot continue using the rapid test. It will not give you any new information. In that case, we will use the RPR. And then the instruction is that we should write a note to the lab saying, this patient has a previous history of syphilis. Please do an RPR. And if the titer is less than 1 in 4, please do a TPHA as well. Then, if the results come back, if the RPR is reactive with a titer of 1 in 8 or bigger, maybe 1 in 16 or 1 in 32, or if the RPR is 1 in 4 and the or less, and the specific test is reactive, and we know the patient has syphilis. And we continue treating. So this one, there will obviously be a delay. This was your first visit. This is already the 2nd visit when you give your penicillin. You write down your titer, you trace your patients, and you continue with your 2nd and 3rd dose. If, on the other hand, your RPR titer is 1 in 4 or less, and the TPHA is negative, or if the RPR is negative, we say the patient is syphilis negative, no current infection, and we continue our routine screening. So this is basically, if you don't have the rapid tests in your facility, you will do this until you get the rapid tests back in stock. Okay, so we've mentioned the 3 injections for syphilis. Obviously, before you inject anybody with penicillin, you have to check if they have a previous history of penicillin allergy. Important thing, though, is many patients will come and tell us that they are allergic to penicillin. But we need to be very sure if the patient's symptoms that they had before, was it a side effect or was it actually an allergy? There's a difference. And our patients don't always know the difference. They just know that they took their antibiotics and they got diarrhea, and now they will tell you that they are allergic. But is diarrhea a sign of allergy? It's not. It's a side effect of antibiotics, right? Any tablet can have side effects. Maybe they took it and they got a headache. Maybe they took it and they got diarrhea or something else. That isn't a side effect. It's not an allergy. So typical signs of allergy will be a rash all over the body, typically like a red rash. It might even be moving around. Bronchospasm, so they were struggling to breathe. Their lungs were closing. They felt like they have asthma. They can become shocked. They can collapse. Or their neck and their throat can swell. Those are typical signs of an allergy. So if they really had an allergy, then, we have to take it serious. But if it was just a bit of a headache or a bit of a diarrhea, reassure the patient that that's not an allergy. It was just a side effect. And then we will continue giving the penicillin. So we give 1.2 million units in each buttock. So it will be 2.4 million units of benzathine penicillin intramuscularly for 3 weekly doses. So we've given the first dose, wait a week for the second dose, wait another week for the third dose. If there's a delay of more than 2 weeks between the doses, then we start from scratch. So we want 7 days in between, ideally. But if she's late by more than another week, more than 2 weeks since the past, then we start from scratch. If we are sure or we are quite suspicious that there really is a history of a penicillin allergy, If it is someone who is not pregnant, we've got alternatives that we can use. We can use doxycycline, for example, as an alternative. But doxycycline is contraindicated in pregnancy, so we cannot use it. The only way that we have that can actually treat syphilis in pregnancy and cross the placental barrier to make sure the baby is treated is penicillin. So in this scenario, we actually have to refer the patient to hospital for desensitization. There's ways of doing desensitization. You give small doses, you give them Solucortef and other things. You have your crash trolley nearby. You have to make sure you have the facilities to manage anaphylaxis in case she does get a real allergy anaphylaxis reaction. This is what we have to do if we are quite convinced that she had a penicillin allergy and she has syphilis in pregnancy. This is what we need to do. So if you're in the clinic, please refer to hospital, include all the results, include the history. If you are in the hospital, make sure to read up on the penicillin desensitization protocol, ask your senior colleagues, and make sure you do this under close observation. Then sometimes we get very curious or very impatient, and we want to check if our treatment has worked. You know, maybe the baby is going to be born soon. We want to make sure, so we want to repeat our RPR. But we can't repeat the RPR too quickly. We should wait at least 3 months until the last dose of penicillin was given. Ideally, if it is early syphilis, so the patient presented with primary or secondary syphilis, or in the first 2 years of latent phase, we should repeat the RPR at month 6 and at month 12. And if it was late latent or tertiary syphilis, we will do month 6, month 12, and also month 24. We can do it at month 3, especially in pregnancy. Sometimes we just want to reassure ourselves that the treatment is working, but don't do it earlier than 3 months. Wait at least 3 months. And then we are looking for a 4-fold drop in the RPR titer. And don't be confused with what this means. All that you will do is you will look at the titer. So it might say 1 in 32. So you take 32, you divide it by 4. You see 32 divided by 4 is 8. So you want it to be at least 1 in 8 or less. If it is 1 in 4, something like that, then you are happy that it's a good response. It usually works better if the titer was high to start with. If the titer was low at baseline, you might not see a very big drop after 3 months. That's why we continue testing it at 6 and 12 months, and sometimes even at month 24, if it was a late latent or a tertiary syphilis. But it might take years to disappear completely. We only need to really be concerned if it starts going up again. So if it's low and it stays low and it just stays low, it's probably fine. But if it starts going up, you have a problem. Then we have to investigate to see if it is coming back. Then, very importantly, don't forget about the partners. All the partners of women with confirmed syphilis must be traced and they must be tested. So if we have enough rapid tests in the facility, we can use a rapid test for the partner of the pregnant woman as well. And we also have to assess them for symptoms. So we want to look for primary syphilis, genital ulcers, and we want to look for secondary syphilis, so the rash or any other problems with the eyes or neurological symptoms or anything else that might be signs of secondary syphilis. Then, if the rapid test comes back positive and they have signs and symptoms of syphilis, we will treat the patient for the partner for early syphilis. We've got 2 options then. If we have enough stock of penicillin, they can get a single injection of the penicillin, so 2.4 million units, 1.2 million in each buttock, just 1 dose. That's fine if they have symptoms, because we know it's early syphilis. Or if we don't have enough penicillin stock, we can rather save the penicillin for the pregnant woman. Remember, this is the male partner. So instead, we will give doxycycline, 100 milligram twice a day for 2 weeks. This is the treatment for early syphilis. Rapid test positive and signs and symptoms of syphilis. However, if the rapid test is positive, but the partner has no symptoms and signs of syphilis, completely asymptomatic, no genital ulcers, no other rashes, nothing else, we'll send a sample to the lab for RPR, and we will start treating them in any case. We don't have to wait for the results. We start treating them. But now, look at the treatment regimen. It's different. Now, they will get the same as the pregnant woman, once a week for 3 weeks, penicillin. Or if you want to save your penicillin for the pregnant woman, you can give them doxycycline. But now it will be twice a day for 28 days. You see, this treatment is longer. If I go back to this slide, where there were symptoms, we gave a shorter course, 1 injection or 2 weeks of doxy. If they don't have symptoms, we give 3 injections or a month of doxy. You see, it looks like it's vice versa. The one with symptoms, we are giving less treatment. And the one with no symptoms, we are giving more treatment. But it's because we understand how syphilis works. We understand early syphilis is more symptomatic, needs less treatment because it's early in the disease. Where if they have no symptoms, they probably have latent syphilis. They've been infected for much longer. The syphilis might be infiltrating more different organs in their body. So we actually need to treat them for longer. Okay, so don't get confused here. Make sure that you remember symptoms, treat for short. No symptoms, treat for longer. Many of our patients will actually need longer course of treatment. And interestingly, if we were very confident in our ability to accurately distinguish between early and late syphilis, even in pregnancy, we could actually apply the same treatment protocols in pregnancy as well. And if the woman has early syphilis, we only give her 1 dose of penicillin. If she has latent syphilis, we give her 3 doses. But in pregnancy, to simplify things and to make sure none of us make mistakes, we just give all of them 3 doses. Remember, most of them are just screen positive because we are testing them at each and every visit, not because they are presenting with symptoms. So many of them will actually be in the latent phase of syphilis if they are asymptomatic in pregnancy and they are testing positive. But even if they have a genital ulcer or even if they have a rash or something that makes you think of secondary syphilis, just because they are pregnant, we don't want to take any chances. So we will always give them the 3 doses in pregnancy. But for the male partner, they can get a discount if we are quite confident that they are in early syphilis. Okay, are we all together? This was the section for the adults, the mothers, and the partners. Now we're going to go to the baby. So unfortunately, about 30 to 40% of babies who get syphilis in utero die. It can either be shortly before birth, in which it's an intrauterine death or a stillbirth, or it can be shortly after birth because they are born with a lot of problems. I'll show you now all the different symptoms it can present with. And this is why we really, really want to prevent it. This is not even the ones that had miscarriages early on. This is the one that managed to carry the baby to term or near term. And as with adults, where I said it can present in so many different ways, in babies as well, it can have so many different presenting symptoms. And those signs will depend on many different things. It can depend on the gestation at the time that the transmission happened. How many weeks was the mom pregnant? What was the developmental stage of the baby at that time? It can be because of the immunological response of the baby, especially if there's HIV involved as well. Maybe the baby contracts HIV intrauterine as well. You know, the baby's immune system will be even weaker, so the syphilis will present in different ways. Also, the stage of syphilis that the mom is in. Is the mom got early syphilis, latent phase? And also what treatment the mom got. Maybe she only got 1 dose of penicillin and then she missed her appointments, or the penicillin was out of stock or something. Or maybe she was treated. So all of these things will influence what symptoms the baby ends up presenting with. And then, interestingly, congenital syphilis doesn't necessarily mean the baby is born with full-blown syphilis signs and symptoms. Syphilis can actually present in the first 2 years of life and still be congenital syphilis. And then we call it early. Up to 2 years, we still call it early congenital syphilis. And then it can even present later on. So if it presents after 2 years, then we call it late congenital syphilis. So even in the baby, it can be latent for some time before the symptoms start appearing. So don't only think of newborns. If you have a baby in the pediatric ward, or you are seeing a baby in outpatients department or in your clinic, and they are coming with some strange signs and symptoms, look back at the mom's history. Remember to test the mom and the baby for syphilis. You might find that it's a late presentation of congenital syphilis. How are we going to manage these babies? There's two things that we always have to keep in mind to help us plan our management. And if we make sure we know those two, then the management will become very easy. So the first thing is the baby's clinical symptoms, and the second thing is the mom's treatment status. If we have those two bits of information, then it's easy. We know what to do with the baby after the baby is born. So if we say, firstly, we need to know the syphilis symptoms of the newborn, these are all the things we need to look at. There can be so many different ways the baby can present. If it affects the brain, the neurological system, the child can present with seizures. If it affects the liver, the child can present with jaundice or hepatomegaly. If it affects the spleen, you might find splenomegaly. If it affects the long bones, you will see long bone changes on X-rays. If it affects the hematological system, you might see pallor. If the HB is low, the baby is anemic. Or you might see petechiae if the platelets are low and the baby has some little bleeds in the skin. If you are there when the baby is delivered, you might find that the placenta is large, pale, and greasy. The baby might be small for gestations because there was intrauterine growth restriction. You might see that very typical syphilis peeling rash that almost looks like a baby with burns. I'm sure you've seen babies like that or pictures of babies like that. They look like they burnt. They're very red with this peeling edematous rash. If it affects the eyes, you might see a baby without eyebrows, with inflammation in the eye, chorioretinitis or a uveitis. You might have a cataract, or if you send them to the ophthalmologist for testing, they might even find glaucoma. The baby can also present with a nasal discharge. You might think, oh, this baby has a flu. Actually, it's part of the syphilis syndrome. If it affects the lungs, the baby can have pneumonia. If it affects the heart, the baby can have myocarditis. So you only need one of these symptoms to actually count as a congenital syphilis if the mom had syphilis. It doesn't have to be all of them. So make sure that you don't get stuck with seizure and you say, oh, it's just, it was a premature baby, therefore he's having seizures. Or the baby has pneumonia, we can treat them with antibiotics for pneumonia. Keep all of these things in mind. Go back and check which of these symptoms might be present so that you don't miss the diagnosis. Okay, so this is the first thing we need to know, the syphilis symptoms that we need to look out for. There are some tests that we can do to help us find all of these things. If you are in a delivery site, you can send the placenta for histology. It helps us as well. Just indicate to them that the mom had syphilis, and you can send that placenta. You have to do a very full neonatal examination. You're going to miss some of those things like splenomegaly or hepatomegaly if you don't examine the baby properly. You can send an RPR on the baby and do a rapid test or a VDRL, just do the RPR. If you are worried about thrombocytopenia because you see petechiae, or you are worried about pallor or anemia because you see the baby is pale, you can do a full blood count. If the baby looks jaundiced or there's any other signs of liver impairment, you can do a serum bilirubin. You can do a full LFTs as well if you want. If you have a cranial ultrasound available, you can do that. See if there are any bleeds or infarcts in the brain. If the baby is symptomatic, you don't actually have to do your long bone X-rays and your CSF, because it doesn't change anything, whether there's neurosyphilis or whether there's X-ray changes on the long bones. So if you have an asymptomatic baby, you might look at these, or if the baby comes with different other presentations. But it's not mandatory to do these ones. then you should refer the baby to ophthalmology to look for the eye abnormalities. It's not an urgent one, so you don't have to rush in the middle of a weekend to get the ophthalmologist on call to come and do this. The baby can get the outpatient appointment for this. And you only need to do the LP if there are CNS signs in the baby. If there's any neurological signs, then you can do the lumbar puncture. Otherwise, it doesn't have to be done routinely if there are no neurological signs. So these are all the things to try and help us to decide if the baby has clinical signs and symptoms of congenital syphilis. And the second thing I said we have to keep in mind to help us to know how to manage this case is the treatment status of the mom. So we know that the mom is supposed to get 3 penicillin injections 1 week apart. If the mom was inadequately treated, or if the mom was not treated at all, then we will manage the baby differently. So what do we mean with inadequately treated? It can either be that the mom did not complete all 3 doses, maybe she only had 1 or 2, or she received all 3 doses, but there was a delay of more than 2 weeks between the doses, or she got all 3 doses, the last dose was less than 30 days before delivery. We need to have at least 30 days between the third injection and the baby being born to make sure that the baby was treated adequately enough. Or if the mom got the wrong dose. So if any of these things happen, then the mom is classified as inadequately treated. Then if the mom is untreated, it means she either did not get any treatment for syphilis, or she was treated for syphilis with a different antibiotic that was not penicillin. Maybe we thought she had a penicillin allergy, somebody gave her azithromycin or something like that. She was treated somehow, but azithromycin doesn't cross the placental barrier, so the baby was not protected, so it does not count. It counts as an untreated mother. Okay, so those are the 2 things we have to keep in mind when we look at our management algorithm. How do we manage syphilis-exposed babies? First category of babies is the one who's asymptomatic. So you know the symptoms. You've looked at all those signs and symptoms. You didn't find any of them. And the mother is fully treated. So she got all 3 injections, 3 consecutive weeks, and the 3rd dose was more than 30 days before the delivery. If all of these things are in place, all of them are applicable, then we don't need to do anything for the baby. Mother fully treated, baby completely asymptomatic, don't need to do anything. Just make sure that the mom's partner was traced and tested so that he doesn't reinfect the mom. Second scenario, the baby is still asymptomatic. We didn't find any signs and symptoms of syphilis, none of those things on the list. The baby is completely well. But if we look at the mom's history properly, we see she was inadequately treated or she was untreated. So you remember all that category of things. Maybe she only got 2 of the doses. Maybe she was treated with a different antibiotic. Maybe the last dose was less than 30 days before the baby was born. The baby is fine, right? This baby is asymptomatic. In this case, the baby will get a single dose enzathine penicillin. It's 50,000 units per kilogram, and it's given as an intramuscular injection. Don't give it IV. Intramuscular injection, and still make sure that the partner, the mom's partner, is traced and treated. Now, if we have a symptomatic baby, it doesn't even matter if the mom was treated or not. The baby has symptoms of congenital syphilis, and we admit the baby and we treat the baby for congenital syphilis. So the interesting thing is that the dose of the penicillin to the baby changes after the first 7 days of life. So if the baby is less than 7 days old, we will give 50,000 units per kilogram, and we'll give it twice a day, 12 hourly. So this is for a baby less than 7 days old. If the baby is more than 7 days, so from day 8 onwards, we still give the 50,000 units. Now we give it 8 hourly, 3 times a day. So we increase the dose. And important, so the total treatment is 10 days, right? But it's not 7 days of BD and then 3 days of TDS. It depends on the age of the baby. So maybe you only started treating the baby when they were already 3 days old. You will give the BD until the baby is 7 days old. So from day 3 to day 7, you will find 4 days. And then you will continue with the 8 hourly, the TDS, from day 8 of life. Okay, so it's not 7 days plus 3 days. It's 7 days plus 3 days if you start on the day the baby is born. If you start a few days later, if you start after 7 days, maybe the baby is 2 weeks old, you will only give the 8 hourly dose. So the dose stays the same, 50,000 units per kilogram. It's just we give it twice a day for the really, really small babies that are less than 7 days old. Yeah, we prefer to give them IV treatment, and then again make sure that the partner tracing is done. Also make sure what's happening with the mom. Check if the mom was fully treated. Maybe the mom needs to be linked to care again. Maybe the mom had treatment failure for some reason. Yeah, so all of these babies will need admission. If you can't manage the baby in your current level of care, you refer them to the appropriate level where they can be looked after properly. Any really symptomatic babies might have to be admitted to a facility with ICU, because some of them can be quite sick. They might have respiratory distress, they might have liver dysfunction, they might have meningitis. Make sure that the baby is in the right level of care. Then, when the baby is 20 weeks, corrected gestational age, we must do a neurodevelopmental examination as well to make sure there's no developmental problems there. And then, if the baby had a positive syphilis serology in the beginning with high titers, we will retest all these babies after 3 months after they were treated. Then again, same as with the mom, we want the drop to be at least fourfold. If it's not dropping properly, then discuss with the specialist. Yeah. And then lastly, remember that syphilis is a notifiable condition, not syphilis, congenital syphilis. So if you have any suspicion of congenital syphilis, make sure that the baby is notified. And it should be notified within 7 days of the diagnosis. Importantly, you should also notify if it was a stillbirth. So if the mom had syphilis and the baby is an intrauterine death, you need to notify that as well. And don't forget about the miscarriages. Any mom who had a miscarriage who also syphilis positive, we should report that as well. And if you are working with women who have a miscarriage, remember some women have a miscarriage before they even came for antenatal visits. They present very early in pregnancy, they have a miscarriage. We treat them, we manage them, and they go along their way. We actually really need to test all of them for syphilis, because maybe the miscarriage was because of syphilis. And if we don't find it and we don't treat it, the second pregnancy is also going to be a miscarriage because of syphilis. And the same with the third. So all of these women who come with a miscarriage, make sure that you test them for syphilis and treat it if it's there, so that her future pregnancies can be healthy. If you want the case investigation forms or more information on the notification process, you can find it on the NICD website. The link is here, or you can just Google the NICD website and search for congenital syphilis. It will give you all the information on what you need to do. And this is just one of those famous quotes about syphilis. They say syphilis is the great imitator. And this guy, William Osler, said that he who knows syphilis knows medicine. And that's exactly because syphilis can present in so many different ways. It can affect all organ systems. If you can understand everything syphilis can do, you can probably manage almost any other patient out there, because syphilis can really act like anything. So have a high index of suspicion. Make sure you test all your patients when you should. Make sure you treat them. Make sure you follow the partners up, so that we can eliminate syphilis or congenital syphilis in South Africa, like we are planning to. There's my references. It was mostly from the DOH BTP guidelines and the Clinician Society Syphilis guideline as well. Thanks. So that's it from my side. I don't know if there are any questions. Don't ask me any difficult questions.
Yeah, Christy. You might not get difficult questions, but there's a lot of questions. So Yeah, just to say thank you, Christy. I think this is a very, very awesome presentation. We really, really appreciate it. And sometimes in life is like that, isn't it? We always see the event, like now you presenting, and but what we don't see is the process, in terms of studying, researching, putting the slides together, organizing the slides so that they tell a story. So yeah, thank you, thank you, thank you, thank you, thank you. I know, because we always do presentations. We know how much time and effort it requires. Okay, yeah, colleagues. Again, thank you for joining us, and it's always awesome to have you here on board. There's so many of you, so I'm hoping that we are going to have some time. Let me see. I think we have some good time to try and go through some of the questions. So maybe let me start, because I've been highlighting, let me see. I've been highlighting some of them. Maybe Christy, as you take a deep breath, let me just answer some administrative questions. Yeah, colleagues, remember, as I said when we start, the clinical care platform is an open access platform in terms of the actual educational content. Issues around recordings and certificates and CPDs, etc. Please do support the platform, become a member of the platform. I'll share the link later, and you'll be able to access all those resources. Otherwise, we will share the guidelines with you, and then you can try and go through. Tulisiwe says, if the RPR is positive, I don't know if it's a question. Okay, it says call the mom for treatment, but nothing said about. I think it was before you covered the issue of the partner. But I don't know if you want to say anything about it. But I think Tulisi, by now we know that we must trace the partners and we must treat them. I don't know, Christy. I think it's straightforward.
Yeah, I think Tulisiwe was just preempting the slide. I hope you are answered.
Yeah, he was concerned about us, the men, during Women's Month. So thank you, Tulisiwe. We will participate in the treatment. Anonymous says you mentioned that there's a rapid test and then there's the RPR test. I thought that RPR was just a type of a rapid test. Unless if I'm mistaken, please shed more light. And before you respond, it's because sometimes when we talk amongst ourselves, we kind of just say everything is RPR, but that's not the truth, Yeah, Christy?
Yeah, I hope it was clear from the slides, but the RPR is this one that you send to the laboratory. So if we talk about a rapid test, what we mean is
Mm,
a bedside test, something that you can do there on the spot, like a urine
mm,
dipstick or a rapid pregnancy test or a rapid
mm,
HIV. So that's what we
mm,
mean if you say a rapid syphilis test. It's that test kit that I showed you the picture where we can get the
mm,
result after 20 minutes. That's not an
mm,
RPR. The RPR is the one where we get the titer. So we have to send
mm,
it to the lab, they test it, and they tell us if it is positive or negative. And if it's positive, they will tell us the titer as well. So it's
mm,
different tests. They work in different ways. The RPR does not stay positive lifelong, where the rapid test will stay positive lifelong. So they work
mm.
quite differently. So let's make sure that we speak correctly, because I think you are right. We become lazy. We speak, we say,
Uh,
did you do the RPR on the woman? Yes, I did. But you actually mean the rapid test.
mm,
So we have to be quite
mm.
accurate when we talk. Yeah.
Awesome, awesome. Thanks for that, Chris. We have many anonymous people. I don't know why. Can't we just request both the RPR and TPHA on the same sample? They are both there on the lab forms already, instead of leaving the lab a note. So it's a question about ticking versus a note. Yeah, I think.
Yeah.
Yeah.
I mean, I'm assuming it's a cost saving issue. I'm assuming that they want us to do the RPR, and then only if it's necessary, because the RPR is negative, then we do the TPHA. Where if we're going to request everything for everyone, then we'll pay for both, even if we don't need both. So I think you need to see your setting, your laboratory. If you see it doesn't work well to leave a note, then you might just have to tick both to make sure at least they are there. But ideally, just to save our tax money, we don't want to be doing unnecessary tests because we pay for all of them.
Awesome. This one is a comment, is a big comment, but at the heart of it, Justice is saying there's a problem with implementation of these guidelines because he says the guidelines are beautiful, but there's an issue with the monitoring and implementation. What has been your experience, Christy, around the level of implementation or adherence to what we are supposed to be doing? Yeah.
Yeah, I think the problem is, like you said, the guidelines are beautiful, but we need all our
Mm,
provinces to order the rapid test kits and to train the
mm,
clinicians to use it. Because I don't know if it was last year or the year before, we started having some of the kits available where I work,
mm,
in some of the facilities, but the clinicians have not yet been called for training. So they were told
mm,
not to use the test kits, and rightly so, because we can't expect somebody to use
mm,
a kit that they weren't trained on. So the test
mm,
kits were sitting there in the storeroom waiting for somebody to be trained. And then even if
mm,
someone is trained, we need to make sure that that training cascades to other colleagues in the facility.
mm,
Otherwise, only Dr. Christie is the only one in the facility that was trained, and she's not on duty today, so we can't do it. So that is the challenge. We have to make sure that we capacitate each other so
mm,
that we get the kits that we need, we get the treatments that we need, sort out our supply chain issues, and make sure everybody knows how to use the kits and how to treat the patients, how to examine them, how to ask the right questions. So
mm.
um, there's lots of challenges, but we can just upskill ourselves, like you said in the beginning, to grow and share that knowledge with our colleagues as well in any platform that we can.
Awesome, awesome. My best friend is not happy. I hear her screaming on the other side. Anonymous says, if the theta is 1.2, do we start treatment? Do-
Yeah,
I'm
I
sure
think
you
it
you
depends.
have more questions for Anonymous, but
Yeah,
Anonymous just gave us a short.
yeah.
Yeah.
I think it will depend on the rest of your story. If it's somebody who's never had syphilis before, your rapid test kit is positive and your titer is 1.2, you will probably start, especially if it's a pregnant woman, because you really don't want to take chances in pregnancy. So you might just treat them, especially if they are pregnant. But you might want to, yeah, get some more information from the patient. Make sure you ask the right questions about the history. Make sure you examine the patient properly at the moment, um, and then you can make a decision. Oh, you
I'm mute because my daughter was not happy, so I thought maybe you know. But Dr. Constable says the lab form only offers syphilis serology and tests for both RPR and TPHA. Should we request them separately as per the guideline? I think it's linked to the previous one we responded to. It's just maybe
yeah.
referring to the form. Yeah. No,
I
I
think
don't
that
think
I think
we.
the key thing is to understand how your laboratory works and what you get when you request which test, so that you apply the right things in your setting. But that's what the guideline is.
Awesome, awesome. Okay, let's move on. I think that one we have responded to. Koroshi says, what do we do when the repeat of the partner is negative? Do we just counsel them on safe sex, or is there any follow-up that's needed for the partners?
Yeah, good point. I didn't actually mention that. I only had the partners that tested positive. So if the partner tests negative and they
Mm,
are completely asymptomatic, then you don't have to treat the partner. So you will just counsel them, maybe emphasize the use of condoms at least until the woman is treated successfully. But if the partner is rapid test negative and no symptoms, you don't need to treat the partner.
I don't know. Brenda's asking an STI management question. How do you administer both penicillin and ceftriaxone if the mother is also presenting with, I think it's the VDS? Let me not mess it up.
Oh,
Yeah.
discharge syndrome.
Yeah.
Um,
Yeah.
I'm not sure if there's a trick to that. I
Yeah.
mean, penicillin is supposed to be split between the two buttocks. I don't know if the ceftriaxone will also go in one of the buttocks. I'm not
But VDS, do we treat it with
I don't know.
yes. Okay, I think I see what you give them. You give them because remember, if the syphilis, ceftriaxone is not the recommended treatment. If you go to our STGs, you have to consider giving penicillin if your patient has syphilis. If you just give ceftriaxone for whatever reason, it's not going to be sufficient, right? So maybe separate the buttocks. Colleagues, I mean, one left for this, right? For this. But if someone is here, I saw Dr. Olga, you are the STI expert. If she's still here, she was asking a lot of questions. Do help us with a response on that one, because I think it's more around the broad STI issues. Is it true that single dose penicillin is enough to treat syphilis? Definitely, or 3 doses as per the protocol? Oh, I don't know about single dose.
Well, I mean, I think if they are not pregnant, then we can treat them with a single dose if we are sure that they are having primary or secondary syphilis. But like I said, in pregnancy, we just give everybody the 3 doses. So if they are
Three
not pregnant,
doses.
then you can, like with the partner, you can decide whether to give a single dose or 3 doses based on the phase of syphilis that you think them to be in. But in pregnancy, we always give the 3 doses.
Yeah, this is something that I think government needs to deal with, because if some of these drugs are not available in private, then they are treated with what in the private sector. That's why we have partially treated type of patients. I don't know about access in the private sector. Christy, I don't know if you have any experience there, but Sibuti probably he's in private. Probably he knows
Yeah.
that there's
I
challenges.
mean, there's been global shortages of penicillin. So it's not just in the public sector. It was for a few years, and then it started being a bit better towards the end of last year and earlier this year. We actually found penicillin in our facilities again. But like I was showing that news article, it does seem like there's more stockouts around the corners.
I mean,
I'm not sure
yeah.
if there's another difference between private and public, but I know shortages were global, not even just South Africa. It's worldwide. So it might
Yeah.
find difficult everywhere.
Yeah, today the questions I can't even help because I don't know section 24 form. So, Ogi, do tell us which one is section 24 form? Is it a consent or you know something about it, Christy? Ooh, sign section 24 form to get penicillin. Is it? I don't know. I don't know.
I'm not
So
aware
if
that somebody
anyone, yeah,
signed
colleagues say
anything.
we are a community or it's a consent form. Yeah, see, they say it's a consent form. Is it for in case they get it? No, usually they don't. We just use implied consent, but you should communicate potential side effects, the potential hypersensitivity, document. I don't know if they need to sign the form. If anyone from DOH knows, some hospital need it in order to give bicillin. Okay, I'm learning about that.
It might be facility specific protocol. So if your hospital or your
Yeah.
district, your province has a certain protocol, then you have to follow it.
Mm,
But I mean, any medication that we give can have side effects. So we don't let patients sign consent for every single thing we prescribe. It's important to counsel them,
mm,
obviously, but I
mm,
don't think it's a national rule or guide that they have to sign consent.
mm.
But if it's your
Consent
facility's
form.
protocol, then you can follow it.
Yeah. Okay. So Anonymous is talking about a patient who's only adherent for the first and second dose, and now they are back after interrupting or defaulting. When they come back, do we start over from scratch?
Yeah, if there's more than 2 week gap between the
Yeah,
doses, then we
between the
start again with
doses,
the first,
we
second, and
start
third dose.
again.
We want 3 doses at least. They should be 1 week apart, but we can forgive them up to 2 weeks. But if it's more than 2 weeks, we start from scratch. That's what the guideline is saying.
Awesome. So what happens? I think is it Emanuela is trying to say after 3 months you see the titers are rising, they are not declining. So he's asking how best do you approach those kinds of patients?
Yeah, I think those are the ones that you would ideally discuss with a physician or an infectious disease consultant.
Mm,
I mean, you
mm,
might have to go and look at your penicillin that you treated the patient with. Was it not expired, or maybe the cold chain was broken? Maybe there was something else that happened. Maybe an inexperienced person gave the injection and didn't, measure it correctly, not give the right dose. So you might have to look into why not. The one good thing about syphilis is, although it's such an ancient disease and we've had penicillin for, I think, 80 years almost, there's no resistance to penicillin. Syphilis does not have resistance to penicillin. It's never been described. Azithromycin does have resistance. I think it's up to about 50% of strains are resistant to azithromycin. That's why we prefer not to use it. But penicillin luckily does not. So treatment failure, if she was treated with penicillin, would not be as a result of resistance, unless we are writing new history here. But that wouldn't be your thinking. Thinking would be that maybe she got a different antibiotic than penicillin. Maybe the penicillin was out of stock. Maybe there was a problem with the actual medication or the dose. You might have to restart treatment. But those are the cases that we would most likely, I would probably say, start your treatment course in the meantime, and then also discuss with AB or with an ID infectious disease physician.
Awesome. But usually this would be patients who are treated with other regimens, especially with the shortages. That's where we usually have issues. Kolosh is asking if there's a room for testing asymptomatic babies in instances where the mom was inadequately or untreated. I think Kolosh sort of thinks that we are only testing sick babies or something along those lines.
Yeah, it's an interesting question, because as we saw, congenital syphilis can even present later on in life. The guideline doesn't specifically say that we should test an asymptomatic baby if the mom was not fully treated. But if you have the option, it might not be the worst idea. It's not strictly in the guideline, but maybe you will find something on the baby. But if you don't do it, as long as you're sure the baby is asymptomatic, I don't think it's strictly necessary. Some pediatricians might have a different outlook and might want to do that.
Awesome. Dr. Constable is back. Do we test the partner as well 3 months after so it's like, is there a particular follow-up for the partner? As remember, we have treated the mom, and now maybe we are doing the 3 months follow-up. Can we test the partner again?
I think it's the same for any adult that has, or any person that has syphilis, whether it's a female that was pregnant at some point or whether it's a male partner. If ever you diagnose syphilis, then you will do your RPR to get your titers, and you will monitor them. You can do it as early as month 3, but month 6 and month 12 can also be done to make sure that the titers drop.
Okay. Dineo says RPR in neonates, doesn't it pick up maternal antibodies?
No, so an RPR is not an antibody test. I think the rapid test and the TPHA, I think the reason why we don't do them has got to do with, you'll find some maternal, if you do a rapid test on the baby, it's positive. It might be because of the mom. The RPR, that's not an antibody test, so you can do that.
Awesome. Yeah. Ramatlape, if you don't have penicillin, syphilis doesn't, actually almost said doesn't like that. I can actually say syphilis likes it when you don't have penicillin, because all other things don't work really. They are not even recommended, and most of those patients will probably have a recurrence of some sort. I don't know. Maybe Christy, the question is: are there alternate regimens that can be used in pregnancy if penicillin is not available? Maybe we can respond to it broadly.
I want to say yes and no. I mean, the reason why someone with a penicillin allergy is referred for desensitization is because penicillin is the only thing that really properly treats it, that you can use in pregnancy, and it crosses the placenta to treat the baby. Azithromycin is an option, but it doesn't cross the placenta. So from the baby's point of view, the mom is untreated, and about 50% of strains are resistant. So it will only work slightly in 50% of cases. I'm not sure about amoxicillin and probenecid. I mean, different people might have different alternative regimens. If your penicillin is really not available, we have to make other plans, right? But you have to keep in mind that from the baby's point of view, the mom is as good as untreated. So the baby will definitely need the single dose penicillin if he's asymptomatic.
Okay, Nolene has a scenario. Hi, doc. I had a first visit ANC who tested reactive for syphilis, but it was a very weak line. We did the RPR and it returned back as very weak. And this means it's a previous. Also, does this mean it's a previous infection? That's what she's trying to ask. Yeah.
Yeah, I mean, it could be, or it could be in the window period, like, early, very, very early
Very early
symptoms.
on. Mm.
Yeah, because if it was a previous syphilis, then that test should remain positive lifelong. I don't know that it would become weak later on. I think it will just give you a positive if it was a previous syphilis. And then a weak reactive, it might show that there's something happening. I would probably suspect it might be a very early infection and repeat the tests after a week or two.
And she's
And
pregnant.
if she's pregnant, I will probably just treat her. I mean, if you have penicillin,
That's why I'm
pregnant, you will
thinking,
just, yeah,
benefit risk. I'm thinking most likely I would consider treating, but yeah.
yeah.
The pharmacists must help us. PENG is a section 1 application. PENG. We apply on a named patient basis. Yo, I don't know about that. No, I don't know. I thought it's a drug that should be available. Is that the form 24? Now we are talking section 21. No, PENG can be section 21. Pharmacists, I know you are there. Please help us. It can be a section 21 drug. We can apply per patient. Is that a thumbs up that I saw? Please confirm.
Maybe it was in the time of really severe shortages that, we were having very small amounts of stock and we had to order it one by one to make sure that we use it for pregnant women and not for non-pregnant clients and partners.
But
I don't think
yeah,
generally.
but section 21 is for drugs that are not registered
We are,
with SAFRA
we are like
or
importing
those
it.
kinds of things. I doubt PENG belongs there. Can I say depends on the hospital? Hey, section 21
It
doesn't
depends on the
depend on the
hospital.
hospital.
Depends on support.
So what you say a drug is a section 121, it means you are recommending as a clinician to use a drug that has not yet fully been registered in the country. So yeah, but maybe section 24 form, which I haven't seen, maybe it may apply. But I don't want to say no because that's what I'm saying. If there are pharmacists here, please help us. I think this one we responded to, so I think I was supposed to multiple partners. Don't forget to probe and treat. Yeah, we know, colleagues. Many people have more than one partner, and please do your tracing. We're gonna continue, colleagues, for the last 5 minutes because I see we have went way beyond, and there was almost 1,200 of you, so we expect that it's a lot of questions. So Amanda says, "Good evening, doctor. This is Sister Amanda from Lenesia CHC, which is in Joburg. I would like to ask, what is the management of a pregnant lady who came in for her first visit? The RPR is negative. However, there is the TPHA is positive." Yeah, I think you addressed this, but yeah, you can summarize it.
Yeah, so if you remember that algorithm that I showed, this will be most likely be a case of a previous syphilis. So the TPHA will always remain positive lifelong, and then the RPR will be negative. So it means no current syphilis. So you don't need to treat the woman, you will just continue monitoring to the RPR at every visit or so the rapid test, this is the one that you will not be doing rapid tests because the rapid test will also be positive lifelong. You will do the RPR at every visit. I think the tricky thing comes in if you don't find a history of previously treated syphilis. The patient denies ever having syphilis, denies ever having injections in the buttocks 3 weeks in a row, and you have this doubt. There's a sign of syphilis, but you don't get the history that the patient was actually treated. Personally, I might consider if she's pregnant to just treat her in any case. But if you do find a documented result in your file with treatment documented, or if the patient says, yes, I went to this other facility, they gave me those injections, then you don't have to treat her again. You will just do the RPR as your screening test at every bank visit.
I wanted to ask you, Christy, as you were going through the guidelines and preparing, what was your sense? Did you feel like they are easy to understand or they are easy to confuse? Because most of the questions, when I look at these questions, I get a sense that people can easily make mistakes in either interpreting or I don't know. What was your sense? Did you feel like it's a smooth road to
Yeah, no,
understanding?
it's not that difficult if you pay attention to it, but there are some small
Yeah.
details that if you just try to
Mm,
think for yourself, you might end up with the wrong result. Like that thing of partner treating. If there are symptoms, you treat for shorter. If there are no symptoms, you treat for longer. If you had to guess, because you were in a training once and you can't remember exactly, you might guess the wrong way around. The one with symptoms, you will treat
mm,
longer. The one without, you will treat shorter. So there's little things
mm,
like that. If you have the guideline in front of you and you follow the algorithm, it is quite clear, especially if you have the
mm,
original version that's in color, because it shows you the green where things are negative and fine, and it shows the red where things are positive, you have to treat, and the
mm,
orange in between. So if you have the guideline in front of you, you follow
mm,
it closely. It is nicely set out, but there's a lot of small little details. So
mm.
don't just think that because you attended one session or one training
What
now
will be
you know
done?
everything. That just means that you know where to find things. You know that they are little details. So pull out your guideline
Uh,
every time when you have a patient like that. Refer back or ask someone to make sure that you are on the right track. Because, um, yeah, I mean, I've
yeah,
presented these slides a few times before in different versions, and every time before I have to teach someone, I have to make sure that I remember all the things
same
myself.
here. I'm like,
Because there's all sorts of little things that we have to pay attention to.
mm, mm. And I mean, we had a Dr. I think it was the part one exam, or there was a huge discussion about specific tests, non-treponemal. Then there was this thing about the reverse what I was like, okay, syphilis, you are that disease. You deserve a diploma on your own. I mean, if you look at Anonymous's question, it sounds a little bit straightforward, but you realize that the you know you so Anuma says in case of a pregnant woman who had syphilis the previous year and was treated and she became pregnant again the following year and the syphilis test is reactive, do we treat again? Anonymous, you need to tell us which test,
Yes.
and did you send a specimen to the lab? I hope you picked up, Anonymous, the tests you need to do for different patient populations, depending on their history of HIV, their history of syphilis, because we can't say yes, we can't say no. We need to know, a little bit more. So those are the challenges. All right. Yeah, so let's see here. Colleagues, I'm taking the last question for the night. Hello, doc. What do you do for a child who comes to the clinic at 6 days postnatal with a mother who didn't finish doses? And who has the symptoms? Is it the child or the mother? Okay, but with symptoms of syphilis, I guess. Okay, Chris, you can respond to it both ways. If the child has symptoms, what must they do? If the mother still has syphilis symptoms, what must they do? Because I'm not sure who still has the symptoms there. Yeah.
Yeah, no, if the child has any symptoms, then you will treat the
Mm,
child as congenital syphilis, regardless of the mom's treatment status and everything. You'll make sure the mom gets
mm,
treated. But if the baby has
mm,
symptoms, you will admit the baby for the 10 days penicillin treatment. If it's the mom who's still having symptoms, you would have to check where, if she missed doses, you might have to restart from scratch.
mm,
And then you have to check what her titers are and if the titers are responding.
mm. I think we must take one more from a colleague from Malawi because in our countries things are not the same. Dr. Christie, how about in the cases where we have a rapid test and RPR? In Malawi, we usually have the rapid tests, and so we end up, or they only have repeat tests. So they end up treating patients endlessly as they keep testing positive. Yeah, it's gonna be tough. Don't you have I don't know, the lab? Are you able to send a specimen to the lab? I don't know, Christy, your advice there? I'm hoping they can send a
Yeah,
specimen somehow.
that's very difficult because the rapid test will stay positive lifelong. So it doesn't help you retreat
Mm,
someone every single time you test them because that test becomes
mm,
useless slightly. So
mm,
if you know that they've been diagnosed before, so you really do need that
mm.
RPR. Between the RPR
Okay.
or clinical symptoms of syphilis, you can help that to guide you as well. But syphilis can
Mm,
be asymptomatic, so you can't say because they have no symptoms, they don't have a new infection. So finding a
mm.
reinfection later on in life will be very difficult if you don't have access to RPR.
Awesome. Colleagues, yeah, it's just after 8 and we still have a lot of questions. I think what I will do, I'll talk to the Dr. Christie. We will export all these questions, maybe create them in themes, and we will have maybe a session without the theory, maybe with just key slides related to those questions and say there's a question about this. Here's what the algorithm says. There's a question about this. Here's what page 9 the guideline says, because yeah, we can't go through all the questions tonight, but just to really, really appreciate you for joining us and being with us up until this time. Dr. Christie, obviously, I was just showing you the questions, but you will see that there's a lot of people who are so happy, firstly, to meet you, but to appreciate all the knowledge that you have shared. It's such a fulfilling thing to empower people, especially if they go and implement. Colleagues, please go and do it. Dr. Christie, your closing remarks. Thank you so much. Yeah.
Thanks everyone for joining us this evening. I hope everybody learned something. Even if you see and treat syphilis regularly, hopefully you picked something up here and there. And if it's not something that you see regularly, maybe you need to increase your index of suspicion because I think they are out there. I think we often miss the diagnosis because we are focusing on the problem with the heart, or we are focusing on the rash, or we are focusing on something else, and we end up missing the diagnosis. So thanks for having me. It was nice to be here with everyone.
Awesome, awesome. Colleagues, I think this one we will repeat. I can show you, and maybe we will take a different approach so that we can respond to your questions adequately. On that note, just to say thanks again, Dr. Christie, and then colleagues, may I wish you a restful night till we meet again on Thursday. The topic has changed on Thursday. We have Dr. Leon. He's going to address us on innovative ways of giving PrEP. I don't know what those things are. We will learn together on Thursday. All right. Thank you. Thank you. Night, night, everyone. Bye.